go live now.
Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to webinar on PPH prevention with Carbetocin. At Hetero Doctors, as you all know, we market products in multiple therapy areas like gynecology, gastroenterology, pulmonology, orthopedics, etc. We have a very strong background in R&D, which is why we try to develop products keeping patient benefit in mind. Our endeavor is to improve patient compliance and ultimately hope to improve clinical outcome. We have developed NSAID patches, reverse treatment patches for patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Frenza. Apart from conventional tablets like Didropal and Mylutin, we market products for vaginal health like Feminora and Pelitra. We also market a vaginal film, a lactic acid film under a brand name Silora. Recently, doctor, we have introduced Carbetocin under brand name Carbiact for PPH. We know PPH is a potentially life-threatening condition and requires intense management. To speak more about PPH prevention with Carbetocin, we have eminent doctor, Dr. Meenu Agarwal with us today. Welcome, madam. Dr. Meenu Agarwal is DNB DGO trained in endoscopy and IVF in Germany. Madam is Bachelor in Reproductive Endoscopic Surgery, certified by European Board. Dr. Agarwal is President, Pune Obstetrics and Gynecological Society 23-24, Chairperson of Imaging Science Committee Fox 2018-25, elected Board Member of International Society of Gynecological Endoscopy. Madam is Course Director, Endoscopic Training Courses in UAE. Madam has over 12 publications in international journals and is the first author of 4 books and has authored many chapters in renowned textbooks. Dr. Agarwal is awarded with India's Greatest Leaders by Asia One, Icons of Health Times Group, Inspiring Gynecologist of West India by Health World, Champions of Foxy by Federation of Obstetricians and Gynecologists of India. Wonderful, madam. Welcome you. Welcome for this and all yours, madam. Thank you.
Yes. Thank you very much, Dr. Prashant, for this kind introduction. Thank you, Hetero Healthcare Limited. Mr. Vijay Kumar is here. Ms. Anjali is here, who has been coordinating with me for a while now and very nicely coordinated everything. And she has also been sharing some studies that you have conducted on this particular topic and on this particular molecule. So today I shall be talking about, one moment, okay. Just give me a second. All right. So today I shall be talking about this molecule, Carbetocin. Okay. So is it a smarter, superior, and safer choice in PPH management? So we have to look at various studies. We have to look at why we need to shift from one molecule to another molecule. Is it giving us a better outcome? Is it safe for the patient, and is it more easy for the doctor to administer molecule, or is it better to keep it in the hospital, especially in the low resource settings where probably the refrigerators and the cold chain is not available? When we talk about postpartum hemorrhage, I think this is a nightmare, not only for the obstetrician, for the staff, for the team, as well as, of course, for the patient's relatives. Patient doesn't know what is happening, but the relatives are definitely, it gets very messy for the obstetrician to explain. It is a leading cause of maternal mortality. Approximately 35% of the maternal deaths are due to postpartum hemorrhage. And when you look at maternal mortality rate, it is 240 in developing countries. However, we are fortunate that in India, it had come down till last year about 106, and this year it is between 95 and 100. And we are also fortunate that in the state of Maharashtra, it is much less, where right now we are all sitting, Nasik, Pune, so it is much less as compared to other states. So when we look at the global PPH incidence, 14 million women suffer from PPH every year, and it is 2 to 4% after vaginal delivery and 6% after C-section. And when we look at the PPH in India, so 38% deaths are due to postpartum hemorrhage. So it is very sad to understand and to know that in the less privileged rural areas, still the facilities of the blood bank, facility to shift the patient to a tertiary center, all those things, though we are better than before, it is still a huge number, a huge challenge which we need to look at for the and how we can avoid it with different other new molecules that are coming into the market. So, what is the impact of postpartum hemorrhage? Of course, patient stays longer in the hospital, higher mortality, higher morbidity, major effect on the families and on the, of course, on the patient later on. We shall discuss about it. The woman does not only go through the physical part, but also psychologically she may get depressed and she may have other postpartum psychosis. She may have problems in lactation. She may also have problems in conceiving the next time, or she may have a psychological block to go for the next pregnancy. In fact, I had one patient last week, she had come, who had severe PPH after her first delivery, and now she's so petrified. Her child is already 7 years old, and she says, "Doc, can you do surrogacy for me, as I do not want to go through the another pregnancy, because that scene comes in front of me, how I was being rushed from one place to the other." So when we look at the clinical findings of postpartum hemorrhage, you have delivered the lady, and you find that suddenly she complains of pain in the abdomen. The abdominal girth is more. You put your hand on the abdomen and you find the uterus is reaching maybe above the umbilicus. Okay, that could be the size of the umbilicus, of the fundus, and then you can see the blood gushing from below. Sometimes it can be concealed, especially in cases of, suppose you have done a C-section for the patient and the blood is just getting collected inside. Most important point is maternal tachycardia. So whenever you see that whenever you feel that this patient could be, she is at a high risk of PPH, always shift the patient with on the finger. And if there is any tachycardia, that is the first sign of the blood loss. So if you look over here, see, first sign when the blood loss is between 500 to 1000 ml, there will be palpitation, dizziness, and tachycardia. So tachycardia is the first sign to come. Whether you have done a TLH, whether you have done a C-section, whether you have done any other surgery where you're suspecting that there could be some blood loss, you want to monitor the patient, first thing is look for the tachycardia. And then as the blood loss goes more, then the BP also slightly falls down. So there will be tachycardia. Earlier BP could be 120/80, and now the BP is coming, say, 100/70. So you know that there is hypotension. And of course, when the bleeding is much more, then it could be marked fall, too much fall in the blood pressure. That means she is going into shock. She is restless. There is pallor. You put the Foley's catheter and you can see the urine output has gone down. And in very, very severe cases, when we say we have put a code blue alarm for the patient, that is when the BP is profoundly fallen and the blood loss is huge. She is collapsed. And of course, there will be no urine. And more than that, then you have to shift the patient immediately to the ICU and start fluids, and you alert everyone, and that is the code blue call that we give in the hospital. So how do we diagnose that the patient has gone into PPH? As I said, that you have to rapidly analyze. You don't have so much of time. So look for the tachycardia, look for any drop in the blood pressure, look for the vital signs, okay, and look for the blood loss. There could be increased in the abdominal girth, or there could be, you can see a frank blood that is you can see that it is coming out. Also a good examination. So So immediately you can put in a, they always look for large instruments. Here there is no point using a small tiny sim speculum or something. So use large instruments, put one speculum down, one speculum up, and on both the sides. Look for any cervical tears, look for any vaginal tears, and or any sign of any hematoma. Or into I'm sorry, I think I did something and I one moment.
No, doctor, no problem. You can just go back a slide or two and start from there. We will edit the session.
Yeah. I think I have to again share. All right,
Yeah.
okay.
The internet was hanging.
Right. Okay.
But just before you start talking, just take a pause of 2 seconds and then start talking.
Sure. Mm, okay. Just give me a second. Let me find the presentation because I have a feeling that this presentation is one moment. Mhm. Okay. All right. No, I have a very strong Wi-Fi at home. Today, for some reason, my Wi-Fi was not working. So then I am doing it with my phone.
My
So
apologies, ma'am, but you are live.
yeah, I know. So I'm just talking. Yes, no problem. I'm just telling a delegate only on my first. So that's okay. Just give me a minute. I'm trying to open my presentation once again. So we discussed about what are the possibilities when there is a PPH. I hope you can see my slides now. So I'll just zoom it and we'll go ahead. Just give me a second. All right. Uh, okay. So it's just loading. Give me a second. I just loading. Give me a second. Can you see my slide?
Ma'am, it's not on slideshow.
Okay.
You
Just
need
give
to,
me a second.
yeah.
Just give me a second. Aryan? 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 एक मिनट जल्दी खोलो बेटा. Switch it off and then switch it off. Switch off.
मैंने कॉल किया 2 बार किया. You want to get connected to your phone?
कौन से किया है?
Ma'am, any issues you're facing, you can send me the slides. I will play it for you.
Dr. Meenu? Dr. Meenu?
I think she has some internet problem, I suppose.
Yeah. Hi, Doctor. So, okay. So now the internet issue is resolved, ma'am?
Yeah, but are my slides seen now?
Ma'am, you
No,
have
not
to,
yet, ma'am. If you can put it on the email to me, I will play it for you.
Sir, Vijay, I have sent you the slides. So, ma'am, I have shared the slides with Vijay. Vijay, you can.
Yeah.
Let
do
me
you want
just
I will
look at
stop
it.
share, Anjali. Will you share the slides?
Yeah, ma'am. Let Vijay to share the slides. I have sent it to Vijay. Vijay.
I am Anjali.
A moment. I'm just pulling it out.
I have stopped sharing. Can you please share the slides from your end?
No worries,
Yes,
ma'am. Just give
yes,
me a
ma'am, we are
moment.
sharing.
Please.
We are sharing, ma'am.
Ma'am, please tell me which page I need to go to. Ma'am, please tell me which page I need to go to. Ma'am, you're on mute.
Yeah. So we were on the fourth slide, I think. Fourth slide. Fourth.
This is the fourth one.
I am not on mute.
Is this the one?
Hello. Can you hear me?
Yes, ma'am, I can. Am I audible to you?
Yeah. So go on the fourth one.
Yeah, this is the fourth one, ma'am.
Next.
See, this is the start.
You are audible. Go for the next slide, please. Yeah. Further. Go ahead.
Still, ma'am.
Go ahead.
Is this the one?
Please go ahead. Okay. One more. Go ahead. No, you've gone back. Okay. This is this we all okay. Fair enough. We can start from here. No problem.
Okay, ma'am.
Okay.
Take a
So
pause. Take a pause.
yeah. No, go back. Go back.
Still back, ma'am?
Vijay, a slide before this.
Go back. You're going forward.
Now I went forward, ma'am. This is the back.
Vijay, मैं बताती हूँ आपको.
Ma'am, or else I'll stop the share. You tell me the slide number.
Yes. This
Ma'am,
is okay.
Okay.
Yeah, right.
All right, I'm going on mute.
Okay.
Take a pause of 2
Thank
seconds
you,
before
Mr.
you
Vijay,
start
for this
talking.
help. Yes. Yes, sure. Okay. So, right. Okay. Thank you, Mr. Vijay, for this help. So now, what are the challenges in the diagnosis of postpartum hemorrhage? One is that what we are doing, we are seeing how much is the blood loss. The nurse comes and tells you that there is no blood loss, patient is doing fine. However, sometimes the vaginal bleeding may be concealed. So when you actually put your hand, you can remove so many big clots because it is a blind pouch, even the vagina. So all the blood gets collected there. The only way to know, number one, the patient may complain of pain and dizziness, and number two, she will be tachycardic. So these are the two things that we should not miss because that will cause a delay in the diagnosis. The second, you can know once you okay, she's tachycardic, and you put your hand, you find lot of blood clots in the vagina, and moment you put your hand on the abdomen, you find the uterus is flabby. Okay, it is a atonic uterus. So that is a underestimation of the blood loss that can happen by the nursing staff. That is why now we have come out with many programs. One of them is Manyata program by Foxy, where the entire nursing staff and the class 4 of the maternity hospital, they go for a training, they get a Manyata certificate, and the small things are explained to them and told to them as to how to manage a case, even of a PPH, before the doctor arrives. Next slide, please. Vijay, can I have the next slide? Hello? Can you hear me?
Ma'am, I'm moving the slide. If is it a challenge? You're not watching it, or?
It's not moving to my end.
You have an internet issue, ma'am. Jyoti, is it visible to you?
Okay.
Jyoti, please respond.
Vijay, I
Anjali,
can
Jyoti.
see active management of third stage of labor. That
Yeah.
slide.
Doctor's internet is a challenge. The slides are not moving there.
Okay. Dr. Meenu?
Vijay, I can see here active management of third stage.
Yes, thank you, sir. I think doctor's hung up already.
Yeah.
She's disconnected.
What if
Let her join back.
what
Let
if
her join back.
if I ask her to join through your phone?
No,
Because
that
that
will
is
be
better.
even worse.
Is it?
Yeah. It's a home internet. That would be faster, actually.
But she is facing some issue, no? I
Let's
mean,
see. Let's see.
into home internet must not be
We can always start all over again. Jyoti,
yeah,
Jyoti.
but we are live, Vijay. You are thinking of recording, but you're not thinking about that we are already live. विजय क्या करना है?
Anjali, give me a moment.
Sure. Yeah,
Okay.
Dr.
Let the doctor join in. What we would do is we'll ask the doctor to start the play again from the beginning.
Dr. Meenu just called me. She's saying that she'll joining again and she'll be sharing slides from her end only.
No problem. No problem at all.
Okay.
First we handed out the first video, and then the game starts. Having 7 questions. The first question we handed to you. So we'll be giving you, there are 7 unique questions. Once you find it, so whoever three participants, if they have a that's called, should submit them by written call or call with the URL. Or running in the board looking for the news. So rest of the team members
Anjali, are you talking to the doctor? Anjali?
No, I just finished talking to her now. She's saying that she is joining. So I
She's
can't
joining
call
it.
her again. Yeah,
Okay,
she's
okay,
about to join. She said
okay,
that she'll run her own slides.
okay. Anjali, are you in contact with the doctor?
Give me a moment. I am on call with Jyoti ma'am.
Cool, cool.
I
No
think I
worries.
should
No
call.
worries. Take your
Yeah.
time. Take your time.
Sure, sure, ma'am. She's just joining. Mira, I'm also getting now call from field. What to tell?
Cool,
Because
cool.
Vijay, we are
Just relax. In case of
live.
any issue, I'm there. If still the doctor is facing a problem with the PPT, I can play it still. But
Yeah,
her
but
internet is so weak that when I'm moving it, it's not moving on her screen.
yeah,
Let's stay standby. I'm here. Just call out
yeah,
for me.
yeah.
Network connection failed.
Should not be a problem, ma'am. You want to start it from the beginning? Oh, she lost it again.
Oh, presentation. Where is my presentation? Can you see my presentation?
Ma'am, we are not able to see your
Doctor,
presentation.
doctor, I think. Mundale problem is.
Yeah, yeah. Okay.
All is well, doctor. No?
Yeah, yeah. No,
Okay, okay. You want to start it from the beginning? That should be better.
I think I will do that. I will do.
Yeah. Let's do it all over again.
Yeah, yeah.
Other than the introduction, we started.
Yes. Just give me a second to open my
Please.
presentation.
Go to the slideshow, ma'am.
Yeah, are we good now?
Yes, doctor.
Yeah. So,
Are we taking it from the beginning, doctor?
yes.
All right, all the very best.
Yes, thank you very much. So, good afternoon, everyone. And I shall be again talking on this new, not very new though, a lot of work has already been done on this molecule, Carbetocin, whether it is the smarter, superior, and a better choice for the postpartum hemorrhage PPH management. When we talk about PPH for a patient, it is a nightmare, not only for the patient's family, relatives, but also for the doctor, the obstetrician, and the entire staff. It is the leading cause of maternal mortality, and it accounts for about 35% of all maternal deaths. And we understand that maternal deaths are much higher in the developing countries as compared to the developed countries. And when we talk about developing countries, about 240 per 100,000. However, we are slightly better off in India, and especially in Maharashtra, the maternal mortality rate in India is around 100, between 95 and 100, and in Maharashtra is much lower. When we look globally, about 14 million women per year suffer from postpartum hemorrhage, which is about 2 to 4% after a vaginal birth and about 6% after a C-section. As I said that about 35 to 38% of the maternal deaths are because of postpartum hemorrhage, higher in the developing countries because they are poor resource setting countries, and a same woman who has PPH in a developed countries as compared to the one who's in a developing country, the resource settings is low in a developing country. So the main thing is how to prevent, how to treat, and definitely we can bring down the maternal mortality rate for these women. What is the impact? Of course, one moment. Just, yeah. All right. Okay, so what is the impact? Of course, the woman has to stay for longer time in the hospital, more morbidity, more mortality. The affected families are also, it causes a lot of stress, not just the mental stress, but also a lot of financial stress that they can go through, and long-term psychological impact. And as I was telling just the other day, I had a patient who already has a 7-year-old child and had a severe PPH in the first pregnancy. And she says, Doc, my daughter as well as my family members want me to have a second child, but I am so psychologically traumatized that I had rather go in for a surrogacy. Can you help me to go for surrogacy for my next pregnancy? When we look at the clinical findings, the most important, first, what is the first thing that we will look for is the tachycardia. So all patients who are at high risk of developing PPH, always shift the patient out of the labor room, or if the patient is already in the labor room, with the pulse ox, so that the pulse rate can be monitored. So here, as you see, when there is about 500 to 1000 ml of blood loss, patient will complain of some palpitation, dizziness, and there will be tachycardia. So this is the right time actually to understand that this patient is going into some problem and then treat this patient. However, if the blood loss increases, you can see about 1 to 1.5 liters, she will still have weakness, sweating, tachycardia, and there may be slight blood pressure fall. Her earlier blood pressure could be 120/80, and now it is coming to say 90/70. So that means she is going into the slightly higher degree of the PPH. And when the blood pressure further falls down, she becomes more restless. And if you have already put in a Foley's catheter, you will realize that the urine output is gone less, and wait for some more time. Or if you have seen an advanced stage of patient is already in severe PPH, that is the time patient is collapsed. You have to call for a code blue. Immediately, you have to have the entire emergency team with you. In the meantime, you take an IV line, put in a Foley's catheter, send the blood for investigations, and shift the patient to the ICU. So initial evaluation, of course, you are looking for tachycardia, hypotension, vital signs. And then the another important thing is look for what is could it be a laceration that she's bleeding? So what is the cause of the PPH? So you put your hand on the abdomen. If the uterus is well contracted, but she's bleeding profusely, she's going into shock, that means you have to rule out any local causes. So nicely take bigger speculums, always take big SIM speculums, put one posteriorly, one anteriorly, look for any cervical tear, look for any paraurethral tears. They also bleed very profusely. So don't miss that out. That is important. Look for the episiotomy site. Sometimes there can be a concealed bleeding. So if you have told your resident to take the episiotomy closure and the angle has not been taken, so the blood is getting collected there, and the patient is initially she will go into tachycardia and then into hypotension. If she's had a C-section, then a good ultrasound will tell you whether there's any collection of the blood in the broad ligament or in the abdominal cavity. Also, if there's any uterine rupture during labor, okay, so that possibility also should be kept in mind, and an ultrasound will give you good diagnosis. So a complete blood count, look for hemoglobin, look for hematocrits and coagulation studies. So immediately you collect the blood and send it. Now, initially you will see that, the patient is bleeding. If the patient is bleeding, you have already diagnosed the patient. The problem comes when there is no external bleeding. So if it is a concealed vaginal bleeding, sometimes the diagnosis of PPH can be delayed. So look for alteration in the pulse rate, alteration in the BP, and if the uterus is flabby in the when you put your hand on the abdomen, and that is when you can, and of course, as I said, put in a big speculum and look for any lacerations. And if you're suspecting of bleeding, which is, post C-section, then you do an ultrasound. Of course, clinically you will find the abdomen is distended. So what are the complications that can happen? Postpartum depression, the lady goes through so much already, and then to go through this PPH, so postpartum depression, sometimes there can be anterior pituitary ischemia. So she may not be able to feed because there is no FSH, LH, prolactin. So even there is no prolactin, sometimes they can go into hypo post delivery. So postpartum amenorrhea, 1 year, 2 years, she is not getting her periods, or they can also be Asherman's postpartum. She can also become anemic. She may complain of a lot of fatigue. Blood transfusion is of course a side effect because you have no other choice but to give her blood and blood products. Myocardial ischemia, dilutional coagulopathy, and of course in very, very serious cases where you cannot do anything, you can lose the patient as well. When we talk about the active management of third stage of labor, what do you mean by active management of third stage of labor? One is that you give some injection to make sure that the uterus contracts. Okay, you can give oxytocin, you can give carbetocin, you can give methergine. So we will discuss what are the possibilities, which injections are, compared with each other, what we can use. Then is when we say active management, delayed clamping of the cord. It generally then, once you have clamped, wait for the placenta to separate and come out, or you can do a controlled cord traction if required. And once the placenta is delivered, then assess the uterine tone immediately to make sure that the uterus is well contracted. Okay, so these so when we talk about these things, so this number one, when we look at the WHO, now WHO, we look for WHO FIGO guidelines for anything, especially for maternal mortality. They are very, very proactive in terms of maternal mortality, and they have run a multicentric trial where they said that we must use uterotonic agents for the active management of third stage of labor. Then how can we prevent the postpartum hemorrhage? Number one, identify high-risk women. When I say high-risk women, women with placenta previa, women with previous history of C-section, women with some kind of coagulopathy, women with previous history of PPH, women with history of APH. Okay, these women are at a higher risk of PPH, twin pregnancy, multiple pregnancies. So all these women are at a high risk of PPH. So these patients must plan for an institutional delivery. We must keep a strict vigilance when she's in the third stage of labor, and a proactive management. So the moment the baby is delivered, we have to think that she might go into PPH, and we have to take the prevention at that time. When the placenta comes out, look at the placenta and the membranes that it is complete. And of course, especially look for any vaginal tear, cervical tear, paraurethral tears, especially if the woman has had a difficult delivery or instrumental delivery. Destructive deliveries we are not doing anymore, so I will not talk about it. When we talk about uterotonics, Okay, so what are the various molecules which are available? We have oxytocin, it is our age old. Then we have carbetocin. Then we have ergometrin, which is methergine. Then we have symptometrin, which is a combination of ergometrin and oxytocin. And then we have misoprostol. We also have prostaglandin in terms of prostadin. Right, so these are the various molecules that we use. And what is the time of administration? At the crowning of baby's head. So you see that the baby's head is crowned, and especially with the previous normal delivery, that in the second contraction she is going to deliver. That is the time you can use a uterotonic, or if she's already an oxytocin drip, that is a time you can increase the drip rate. At the delivery of anterior shoulder, I think when I was in Armed Forces Medical College, that is the time when they used to inject uterotonic at the delivery of the anterior shoulder. At the end of the second stage of labor, most of us give uterotonics at the end of the second stage of labor. And of course, following the delivery of the placenta, also it can be used. So how do we prophylactically use it? Why do we use it? Because we want to prevent PPH. And this is called the active management of third stage of labor. And of course, if the patient is already gone into PPH, then it will be a therapeutic use of the same molecules that we can use in cases of PPH. So when we talk about the PPH treatment, the lady already she is bleeding, then the blood loss, it can be various stages, stage 0, stage 1, 2, 3, 4. As the blood loss is increasing, the volume loss is increasing, then in the especially action line 1000 to 2000, urine output is gone down, the pulse rate has gone up, respiratory rate has gone up, she has postural hypotension, and she may also be in shock. So these are the first less than 500, you got to prevent it, then alert line, and then the action line. So what we do, we use uterotonics. We can also use tranexamic acid, very, very important. In fact, most of the now studies have shown that prophylactically give 1 gram of tranexamic acid whenever you are taking the patient for C-section pre-operatively. Uterine tamponade. Uterine tamponade generally when you're doing a C-section. Okay, so what you can do is you can you can take a stitch and you can kind of tie it. So that tamponade we can use, and of course surgery in a very, very difficult patient. I remember in Ruby Hall once I was in the hospital, and at 10 o'clock in the night, patient was moved in from periphery with a hemoglobin of less than 4 gram % Her blood was like water. She was PPH, but it was not looking like blood. And we had to take her up for a emergency post delivery hysterectomy. So sometimes you may have to go for either anterior internal arterial ligation, iliac artery ligation, or for a hysterectomy. So these things are not uncommon and can be resorted to, especially in absolutely in the last group, when you know that you might lose the patient if you don't do anything. Then what are the challenges? Okay, we talk about oxytocin. Oxytocin has a very short half-life. So you need, number one, appropriate training to the clinical staff. You need to monitor the patient. You need to start on a drip to the patient. Okay, so it is not that you can just give it intramuscular. Then we have symptometrin. We have been using it, and only problem with this is they have nausea and vomiting. Even with methergine, methyl ergometrin, they have nausea, vomiting, and in fact so much that we first give something like Rantac and then give the patient either Cinto or methergine. And then we have oral misoprostol. We can also use per rectal misoprostol, because per vaginal it will not help. So either oral, sublingual, or per rectal misoprost we can use. Very main problem with miso is they have lot of shivering. So that is a main problem. And also, of course, nausea, vomiting, and diarrhea you can many times find with meso. So what is the WHO recommendation of Carbetocin for PPH? So WHO recommends use of effective uterotonic for the prevention of PPH during the third stage of labor for all births. So every childbirth, the moment the third stage, say the baby is delivered, you give a uterotonic, which is the recommendation by WHO. So you can use oxytocin, you can use carbetocin, you can use meso, you can use ergometrin, and or ergometrin with oxytocin in a fixed dose combination. So these are the various molecules that you can use. Either of them you can use, but we look at what are the advantages of one molecule over the other. Now, one very, very important, it is even mentioned in the WHO manual that carbetocin is now available at room temperature. That means in low resource settings, suppose I am in a periphery, small little nursing home, there is no refrigerator there, or there is a primary healthcare hospital where there is no refrigerator there. So this can be kept in the room temperature. So as compared to if you are using oxytocin, you need to keep it in the refrigerator. So that is a very, very important thing, that we don't need a cold chain for this molecule to store it and also to use it. So it is stable at room temperature. And when we look at the difference between oxytocin and carbetocin, it is actually a type of oxytocin, the molecule, but it is a better molecule because you can give it in a single dose, and you do not, it has a better half-life as compared to oxytocin, and it is an analog of oxytocin, you can say, but it has a better half-life. It does not require refrigeration, and cold chain it does not require, and it can be given in a single dose as compared to be given as a drip for a longer time. So the mechanism of action you see over here, it releases this free calcium, and this free calcium is converted to calmodulin, which are acting on the myosin, the muscle fibers of the and causing the uterine contractions. So single IV dose of carbetocin, 100 micrograms administered after the delivery of the baby, is sufficient to maintain adequate uterine contraction. So you don't have to continue giving IV drips. एक में डालने हैं, second में डालने के नहीं डालने हैं. So just a single dose, 100 microgram, moment the baby is out, you give this injection. It will prevent uterine atony and excessive bleeding with efficacy comparable to hours of oxytocin infusion. And you look here, the moment you give the injection, single IV dose, within 2 minutes, it starts acting. So the onset of action is about 1.2 minutes, when about 1 minute, you can say 1 to 2 minutes, when you give it IV, and intramuscular 2 to 3 minutes. And oxytocin, of course, you have, if the drip is already on, you can start the drip, and intramuscular again 2.5 minutes. The duration of action is about 60 minutes with a half-life of 40 minutes. Oxytocin has a very short half-life, you see, just about 3 to 5 minutes. So you have to continuously give it. In carbetocin, you can give just one single injection. IV, it will last for an hour, and if you give IM, it will last for about, the effect will last for about 2 hours. So it is a good idea to use something which we can give single dose, and the effect will be longer. Also, suppose the drip is going on and the drip gets blocked, or the needle moves, although we are using intracath, but all these things can happen once you leave the hospital. So giving the single injection in front of your eyes, IV or intramuscular, is still, I would say, a better option than leaving the patient on the staff and on the on your nursing team. As I said, that oxytocin is analog of it's very, the carbetocin is an analog of oxytocin. Okay, so, but it is 24 times, it is less potent. Okay, and so it does not cause hyponatremia. So that is a very, very important thing. What oxytocin does, it causes a lot of fluid retention. I'm sure most of the gynecological obstetricians who are listening to this talk, we know that there's a lot of fluid retention with oxytocin, and with carbetocin, it is less potent in terms of fluid retention. So less fluid retention and less risk of any hyponatremia. So these are the important things. And oxytocin has antidiuretic effect, and that is how there is water retention. And sometimes it can be really bothersome. There are cases known who have gone into pulmonary edema because of the water retention that happens with oxytocin. So when we look at the clinical evidence, what we need to look, we have discussed, we know that this is better in terms of its half-life, it is better in terms of a single dose, it is better in terms of water retention, but is it as effective as oxytocin, the other part? So let us look at the clinical evidence, efficacy, safety, whether it is superior, same, or not inferior. So we need to look at those options, and whether it is better to go for a single dose or the continuous infusion, and of course efficacy, safety first, whether it is safe to give as compared to the other uterotonics. So there are a few studies that I will be talking. This is the champion trial, which is a Carbetocin hemorrhage prevention trial. It is the largest clinical trial conducted by WHO in the prevention of PPH. So what was the study design? They took 30,000 women across 10 countries, okay, including India. And what was the primary outcome? Whether the blood loss was at least 500 ml, at least that much, or with when we have added the uterotonic agent. So the blood loss will reduce, okay, and or women where the blood loss was reduced by 1000 ml. So let us look at this result. What was the result? The frequency of blood loss of at least 500 ml or the use of additional uterotonic agent with carbetocin was proven to be non-inferior versus oxytocin. So they used oxytocin, they used carbetocin, and they did not find the carbetocin was as effective as oxytocin. All right. And there was no difference in the adverse effects whenever these were used to stop the bleeding. So patient already had PPH. In one group, they used one oxytocin. In the other group, they used oxytocin and carbetocin, and they did not find much difference between the two groups. So carbetocin was not inferior. It was as good as oxytocin for the prevention of blood loss of at least 500 ml or the use of any additional uterotonic agents. So this was another group you can see here. So what was it was a meta-analysis in 5 trials where 617 patients in carbetocin group, 597 in oxytocin group, C-section deliveries. And what was the primary outcome? Whether they needed an additional uterotonic, and the outcome was the patients treated with carbetocin had less need for additional uterotonics as compared to those treated with oxytocin. So here carbetocin fared better than oxytocin, as they did not require the use of additional uterotonics. Then shall we go for a single dose carbetocin? Again, a prospective case controlled study, and they all were going in for an elective C-section and were at risk of PPH. They gave 100 microgram IV at delivery, and here they gave 20 units of oxytocin in 1000 ml. That means 10 units in 500 ml at the time of delivery. And they looked at the impact of the blood pressure, uterine tone, and uterine position, which was monitored at 2 hours, 12 hours, and 24 hours after delivery. And what was the result? The result was a single injection of carbetocin was found to be more effective as compared to the continuous infusion of oxytocin in preventing PPH. So again, another trial here, you see almost about 1,200 patients, at least one risk factor for PPH, and they compared effectiveness of carbetocin with oxytocin. It was a randomized control trial, and the result was that management with carbetocin is associated with greater reduction of PPH as compared to the oxytocin. Now, so again, this is a randomized double-blind controlled study. 314 patients in carbetocin group, 310 in oxytocin group. Again, what was the primary outcome? Blood loss of at least 500 ml within the next 24 hours, and carbetocin significantly decreased the risk of manual removal of the placenta. And best agent to reduce PPH, especially if it is more than 500 ml, and there was a decreased need for uterine massage and for other uterotonics in this particular study. And compared to oxytocin, when we use prophylactic treatment with carbetocin after an elective C-section, it reduces the risk of additional uterotonics by more than 50%. This we already discussed in another study by WHO. And this is, so how they have used here, they used oxytocin bolus 5 units or 10 units, followed by 10 units in the drip in 2 hours. And here they used direct carbetocin, single dose 100 microgram. And that is how the comparison was done in this particular study. So when we look at the women who are low risk of PPH, when I say low risk, that means they're singleton pregnancy, they are not twin pregnancy, the placenta, it's not placenta previa, there is no previous history of any PPH. So these patients, again, as you can see, carbetocin administered a single dose of intramuscular injection following the vaginal delivery. So they used symptometrin, and then they used carbetocin. And what was the result? They found that carbetocin was more effective as compared to symptometrin. So reduction in postpartum blood loss, smaller drop in hemoglobin levels, and less adverse effects makes carbetocin more effective as compared to symptometrin. It also has a good safety profile. The vomiting is lesser. It is not zero, it is lesser. Nausea, vomiting also lesser. Headache is lesser as compared to oxytocin. And of course, as I said, the water retention, leukocytosis is again lesser with carbetocin as compared to with oxytocin. So because of its water retention effects, and it can cause hyponatremia. So heart disorders are higher with oxytocin. So patients with cardiac disease, I think we should not give them oxytocin, and carbetocin is a better molecule. Less incidence of skin rashes and less incidence of any vascular disorders. So it is a promising agent for PPH prevention. So what we do is we give intramuscular single injection 100 micrograms the moment the baby is delivered, before the placenta is out. Less blood loss, better tolerability as compared to the oxytocin and symptometrin both. And so even when we are going in for a C-section, so we can use carbetocin as compared to the group receiving oxytocin. PPH is much lower, so that is a good option to go single dose as compared to oxytocin. So here again, when we are talking about the management, see here now we discuss about the prevention, and when we're talking about the management, again carbetocin is found to be better efficacy as compared to symptometrin in the management of postpartum hemorrhage. How about with mesoprost? So we can also use mesoprost, sublingual, per rectal. So these are the options that we have. However, when we look at the studies, we have found that intravenous carbetocin it has similar efficacy to sublingual mesoprost or and oxytocin. So you give sublingual mesoprost and you give oxytocin. So putting these two together as compared to IV carbetocin, so both have the similar efficacy. So you can use either of the two. So what are the guidelines by various societies? So if you look at, see, again, these Canada Society, very strongly they are recommending the use of carbetocin. WHO is recommending all these molecules. They say any uterotonic should be used once the patient delivers. However, they have put oxytocin as number 1 and carbetocin on number 2. So these are the molecules can be used, either of them. And when we say either of them, we can again compare which is a more easier one to give for us, and where we have most important with carbetocin, what I find the difference as compared to other molecules, that it does not require a cold chain. It does not require to be kept in the refrigeration. So this is one of the important things that we have to keep in mind. So as you see here in Canada, 100 micrograms IV bolus in the active management of third stage, New Zealand, FIGO, Germany, Austria, Swiss body, FCOG, France. So they have been very supportive, very positive for the use of carbetocin in the third stage of labor. So to conclude, I would say that postpartum hemorrhage is a significant, I would say in India, it is the most common cause of maternal complication and death. And it can occur even in a woman who's not at risk. Very difficult for us to explain. They say, doctor, aapne bola tha sab acha chal raha hai, how can she still have a PPH? So PPH can happen even in a woman who's not at risk, and it has a major impact on the patient as well as on the families. So the WHO recommendations are that we must use a prophylactic uterotonic for the active management of third stage of labor, and this can reduce the risk of PPH by more than 40%, and risk of doctors having a heart attack also by more than 40%, because PPH can be very, very taxing for the doctors itself. Carbetocin, as I said, is an analog of oxytocin, but it is long acting. It has a longer half-life. It is stable at room temperature. It is as good as in terms of efficacy and safety profile as oxytocin, and can be used for its better properties in place of oxytocin. And when we look at the champion trial, as I said, that we found that it was found that carbetocin was not inferior. It was as good as oxytocin. However, it does have its own positive points, wherein you can decide whether to use oxytocin or to use carbetocin. So compared with symptometrin and misoprostol plus oxytocin, it shows better hemoglobin levels, lower risk of hypertension, lower risk of water retention and pulmonary edema. And these these are much better for patients with cardiac disease, okay, because there is no water retention. And WHO, as I said, FIGO, the Canada Society, the New Zealand Society, they have recommended the use of carbetocin in the management of postpartum hemorrhage. So thank you very much. And thank you, Anjali, for sharing these slides with me. They were wonderful. I did make a little bit of changes here and there, but it was very, very nice. So thank you very much. The Hetero Healthcare, Dr. Prashant, Dr. Anjali, Mr. Vijay Kumar, all of you who are here. And I'm extremely sorry that there was a little bit of glitch in the beginning because of the internet connection. Thank you very much. Thank you.
Thank you so much, madam.
Thank you.
Vijay, you stopped my video?
Yeah, I just stopped the screen share.
I think my video somehow, I do not know, it's getting stopped. Madam, there are a few questions. One minute. I'll
Okay.
start my video. 1 minute. It started now.
Sure.
Can you see me? Can you hear me, madam? It
Yes,
has
sir.
been a wonderful session. Now all this the unexpected thing happens not only in gynecology, but even in IT when we present.
Yeah.
Obstetrics is one thing which is always full of emergencies, and why not a presentation? When you're presented, Carbetocin obviously appears to be the best amongst what is available currently. Would you
Yeah.
recommend it to be used prophylactically in all the pregnancies in third stage of labor?
Yeah, of course, of course. That is what not
Yeah,
my
correct.
WHO recommendation.
WHO, correct. Because then we would prevent a lot of complications.
Right.
Just a very interesting question that came. If oxytocin is used antepartum, most of the doctors use for this thing, cervical dilatation, etc. Can carbetocin be used postpartum,
Yes, you can use it, no problem.
provided there is no oxytocin fatigue
Because
or
oxytocin has a very short half-life. You stop
correct,
it and the effect goes away.
the effect goes off.
Carbetocin, no
But
problem.
if the patient is not responding to oxytocin, obviously carbetocin will not work. What would you suggest in those cases?
No, first of course is the medical management. Okay, so
Yeah.
whenever if the patient is, you are talking about the therapeutic, not prevention.
Yes, I know.
In therapeutic, you would of course give whatever is available
Yeah.
to you. If you have carbetocin, oxytocin, everything you will give. You will go for the uterine massage. You will look if there's any lacerations around which are bleeding. But
Okay.
if it is a definite PPH, the uterine massage will help. Other things, you can also use those Foley's catheter, place it in the inside the uterine cavity, inflate it.
Okay.
And that stops the bleeding. And of course, if nothing is working out, you can either go for the internal artery ligation, or sometimes even for the you may have to go for a post-delivery hysterectomy.
Hysterectomy.
Yes.
How common is PPH in patients with high risk factor, like for example in patients with fibroid?
Mhm. Yeah, patients anywhere where the uterus is not able to contract.
Yes.
So whether it is placenta previa, twin pregnancy, triplet pregnancy, fibroid uterus, all adenomyotic uterus, all these will cause irregular contraction of the uterus, and that is how it.
So in these cases, it's certainly better to start carbetocin straight away in the third stage.
Of course.
There is one question: how would you manage a PPH patient in retained placenta, especially a second trimester MTP?
Second trimester MTP, generally, whenever you're doing a second trimester MTP, one thing which is very important, two things. One is never rupture the membranes.
Okay.
It will come out and sac. Just wait. Sometimes they're impatient. They rupture the membrane. They want to pull. Second thing is, once the fetus is expelled, just clamp the cord. Don't do anything. She will not bleed at all. The moment you try to pull on the cord, they are very thin and very, second
delicate,
delicate. So it breaks off, and then you are landing. And of course, if there is retained placenta, you have to take the patient into the OT and do a manual removal.
Yeah, that is the last resort.
Correct.
Now, cold chain appears to be really a problem in country like India, even in metros.
Right.
Because we, even in Mumbai, because of this heat, excessive use of electricity, many of the places there is a power shortage. And if electricity goes off, then we do not know the refrigerator and oxytocin efficacy. Really, it appears to be a bigger challenge than we really think, cold storage.
Yeah.
And now another thing, is a very interesting question. This question is not from any doctor, it's a question from me. Looking at all the pluses of carbetocin over oxytocin or other uterasonic agents. Why is carbetocin not really gone up to that level where it should be until now? I'm not talking about a brand, I'm talking about carbetocin as in general.
Yeah, I understand. It's very difficult to change. Clomiphene citrate
Correct.
lasted for 70 years before now. Finally, Ashray came out with first line of treatment is letrozole. And
Absolutely.
citrate. So it takes long. Whatever we have been using, it takes time to change. I think.
Amoxicillin still remains the first line of therapy,
Right.
even after so many years. And really, in real life situation, how common is oxytocin fatigue?
Oxytocin.
Fatigue in the sense not responding to oxytocin, overuse of oxytocin.
It's quite common.
Quite common.
It's quite common. Yes.
Okay.
Yeah. Fortunately, we have prostaglandins now. So where
Correct.
we
And in
always-
oxytocin fatigue, I suppose prostaglandins are used more than even methergine.
they will be effective better than even carbetocin in those cases.
Obviously, carbetocin. And between prostaglandins and methergine, what would you prefer in those cases?
Always prostaglandin.
Prostaglandins. Okay. I think that is all,
Mhm.
But of course, if there are some more questions, we'll definitely come back to you.
Most definitely, no problem.
Thank you so much, madam. It was wonderful, It was a sort of a CME to even me.
Thank you. Thank you
Thank
very
you
much.
so much. Thank you.
So thank you. Anjali, are you there? Anjali, are you
We are here, ma'am. Just a moment.
Please handle with care.